Hello, this is Dr. Bernstein with the September 2017 issue of our teleseminar. Before we answer questions, I'd like to remind you that there are some things for you to think about. The answers I give are guesses. I haven't examined you. I haven't gotten a complete medical history. I don't know what medications you're taking. I don't know your family history. So all I can do is read what you tell me and then make a guess. And the guess could be totally wrong. But the guess is worded so that it'll be helpful for the other listeners. We have no special subject this month because we have so many questions. First question. I can't get any other strength of insulin than U100 Humalog. We don't have dilution solution available in New Zealand. Curious to know if I can dilute with either sterilized water for injection or sodium chloride 0.9%. You cannot use sterilized water because it does not have the same osmolality as human serum. But the 0.9% sterile saline does. And there has been at least one study showing that you can use saline, 0.9%, also called normal saline, for diluting insulin. Now, there are some insulins that you cannot dilute. Usually the longer acting insulins. You can dilute I'm trying to think. You can dilute NPH. That's the only long acting insulin that I know of for sure. And you can certainly dilute all of the rapid-acting insulins, such as Humalog, Novolog, and regular insulin. Is kidney disease from diabetes reversible with good blood sugar control? Well, those of you who have read my book know my history, and I had pretty severe kidney disease back in 1969 and totally reversed it by having normal blood sugars. Now, as a rule, and I'm not absolutely certain of the numbers, if you have a creatinine clearance, which is a measure of total kidney function, of over 45 or 50%, which is about half of normal, you probably can restore the full creatinine clearance with normal blood sugars. I say probably. If it's less than that, kidney disease can perpetuate on its own, even though the initial cause, the high blood sugars, goes away. So as the lower your creatinine clearance, the less likely that the kidney disease will not progress. So if you have a creatinine clearance of 20%, you may be stable given normal blood sugars, and I've seen a number of patients hover at 20% for years and years. If you get under 20%, you're almost certain to deteriorate because the kidneys are what the remaining surviving cells in the kidneys, filtering cells, are overworking. How did Dr. Bernstein manage to check his blood with the very inaccurate monitors of his early days? Well, the monitor that I used in my early days was quite accurate. Other people were not using them. They were only being used by emergency rooms. This is the 3-pound meter that I've shown on my videos before. It was difficult to use in that you had to squirt water on the blood after a minute. You had to time it, squirt water on the blood that was on the strip, then blot the strip, and then put it in the meter. But the meter had a way of calibrating it against the standard solution, and the standard solution was 100 milligram per deciliter, so it was quite accurate in the normal range. Like the modern meters, however, it was not accurate at higher blood sugars. And since I'm shooting for normal blood sugars and was shooting for normal blood sugars pretty rapidly back then, it was accurate for me. And it was probably more accurate than the less accurate meters that are available today. Today we have some that are very accurate, like 2 that we've recommended, but there are others that are grossly inaccurate. One of the more popular meters, according to the insurance companies, probably because of its price, although there may be some paybacks by the company that makes it, can be 50 or 100% off, even at normal blood sugar values. So there are some very inaccurate meters around, and there are some accurate ones. What vitamin and mineral supplements are good for diabetes type 1 and why? If you're following a low-carb diet, eating a mix of vegetables, low-carb vegetables, and you don't need huge amounts, and let's say occasional red meat, fermented cheese, and oily fish, you're probably getting all the nutrients you need and don't need any supplements. Now, there is a lot of evidence that CoQ10, coenzyme Q10, also called ubiquinol, can protect against tooth infections or gum infections. So that might be recommended. You could possibly consider that. The reason I say that is because I rarely encounter a diabetic, either type 1 or type 2, over the age of 40, who hasn't had root canal treatments, which meant infections in the roots of teeth. So since this is so common amongst diabetics, the CoQ10 is worth considering. If you buy it under the name ubiquinol, you take 100 milligrams per day. If you buy it under the name CoQ10, you take 200 milligrams per day. But as a rule, I don't advocate supplements. I've had a number of patients who were taking supplements and had adverse effects. One exception, vitamin D. I forgot about that. In our country, even in the sunny climates, most people live in air-conditioned homes, air-conditioned cars, and rarely go out in the sun. So they're not getting exposure to the vitamin D effects of ultraviolet light that our ancestors received, and they usually need supplemental vitamin D to attain reasonable vitamin D levels. And that's why I check every new patient for their serum vitamin D level and recommend supplementation with 25 hydroxy vitamin D3 if their levels are below 50. And we try to get them up to around 100. Now, that's an arbitrary number. There is evidence that perhaps it should be higher, but there's been controversy about this. I stopped eating sweets and sugar cold turkey 10 years ago. Metformin worked, but of late metformin messes my digestion, and have thus reduced dosage. I am a complicated case, but what else can I do from diet to offset insulin resistance and weight gain? Well, this is clearly someone who hasn't read my book, doesn't know about low carbohydrate diets, and I would say that number one is to cut way back on the carbo, read my book, Diabetes Solution, or Diabetes Diet. If you're taking metformin, it shouldn't be the generic. It should be glucophage XR. It could be that the metformin stopped working. It's now messing your digestion. Could be that different generic versions of metformin have different effects on digestion, frequently causing diarrhea. So if you try the glucophage, especially the slow-release glucophage XR, less likely to get diarrhea. Other substances you could use would be Avandia and insulin. Avandia is an oral medication that should not affect digestion, and another consideration is using very small doses of a long-acting insulin like Tresiba. All this is in my book, Diabetes Solution. I have GERD, that's gastrointestinal reflux disease. I appear to be insulin resistant and pre-diabetic. My doctor has told me because of the GERD, I cannot tolerate fats. I want to follow your diet. Please tell me what I can eat. Well, first of all, if someone has told him he is pre-diabetic, the chances are that they got the information from some blood sugar reading or a hemoglobin A1C reading. And once the A1C is over, let's say, 5.3 or so, which would be an average blood sugar of about 112, or fasting blood sugar over 112, I would recommend that I usually treat people as if they're diabetic, put them on very low carbohydrate diets. And in this case, the person was told that he should avoid fats, but fats are not necessarily the cause of GERD. Amongst diabetics, the more likely cause is gastroparesis. And if this person has had elevated blood sugars for years, he probably has gastroparesis. One can determine that by doing an RR interval study, which we've discussed in my videos and also in my teleseminars. So the important thing is first to control blood sugars, and then you could do experiments with fats to see if they make the GERD worse. There's a good chance, I'm not guaranteeing it, that by lowering blood sugar, the GERD will ease up. And then if you can test it with fat and find that you don't get the symptoms, the burning in the midline of your upper chest, you may not, fats may not be the cause. If you've had gallstones or gallbladder surgery, that's a totally different story. There you need to cut down on the fats. This is a nutrition specialist talking about a type 1 who was diagnosed 2 years ago at age 17 with a fasting blood sugar of 450 and was making some insulin and had islet cell antibodies. She's on an insulin pump. Is there a chance that this patient could be a type 2 diabetic? This is, the question itself is a fallacy that I frequently encounter. I often get questions from doctors is this patient a type 1 or type 2 because the treatment is different. Not for me. For me, the treatment is whatever normalizes blood sugar. And I have obese type 1s who get medication that lowers insulin resistance so that their insulin doses can be reduced. I have type 2s who are receiving injected insulin, both basal and bolus, either because they've waited too long to treat and they've burned out much of their beta cells, or even though their diabetes may be very mild, we're doing our best to keep their blood sugars absolutely normal to prevent further beta cell burnout. So you can use both the medications of type 1 and the medications of type 2 for either type of diabetes given the right circumstances. So I consider diabetes a spectrum, a continuous spectrum that goes from severe type 1, where all 100% of the beta cells have been destroyed at one extreme, to very mild type 2, or what they may even call prediabetes, where your fasting blood sugars are all in the 80s, but you go up to 130 after meals. So there's a spectrum, and you do whatever you can to keep the blood sugars normal or around 83 all the time. You don't worry about what you want to call the disease. Another question. I believe there is a genetic reason for diabetes. What is your opinion on this? Well, the scientific literature repeatedly seems to indicate that both type 1 and type 2 diabetes have genetic components and environmental components. I've yet to read an article that shows that it's exclusively one or the other. So it's complicated. Lantus is working well as I am in a low carbohydrate, high fat diet, but my blood sugar is usually about 100 and below 120, which I think is not good. So what is your advice? Well, first of all, I don't like the term low carbohydrate, high fat, because it implies that they're ignoring protein in some manner. And what I advocate is low carbohydrate plus the necessary amount of protein to maintain your muscle mass in the light of the amount of physical activity that you get. And then whatever fat comes with the protein or carbohydrate is sort of free. I don't try to deliberately feed people vegetable oil and things like that to build up the dietary fat. And what I find is that this approach works. Now, if this person wants to get their blood sugars down a little bit, he could consider getting Glucophage XR, which is the slow release of the brand name for metformin. He certainly can follow a low carb diet with adequate amounts of protein, might take small doses of Tresiba insulin, might take Avandia if he's overweight. So there are lots of things that could be done. I think he or she should read my book, Diabetes Solution. Ten-year-old girl on low-carb diet. Her blood sugar not high. Not high before meal, maybe 95. After meal, maybe 130. And she has ketones. She's on a low-carb vegan diet. What she need to know to get ready to get rid of the ketones. Why do you want to get rid of the ketones? Again, if you've been following my videos or my teleseminars, you know that ketones are essential for the survival of the human race. And the vegan diet, on the other hand, which usually deprives people of protein and usually also gives them too much carbohydrate, stands a good possibility of impairing growth. I've seen kids on vegan diets because their parents had a religion about it, and they usually were underweight and had not grown according to their original growth curves. So the important thing is to go after blood sugar and to try to give people adequate nutrition, not vegan nutrition, which cuts down on protein and can have adverse consequences for a growing person. I have normal ranges of blood sugar during the day, but when I wake up at night or just before going to sleep, my sugar levels rise. I don't understand because when I wake up in the morning, the levels are normal. I take metformin 500 milligrams in the morning and evening. When I took 500 milligrams 3 times a day, I felt really sick. Okay, the first thing I would do is read my book, Diabetes Solution, because a lot of this depends on the diet. Then I would switch from generic metformin to glucophage, and you might try the rapid-acting glucophage before each meal to prevent blood sugar increases after meals. And in particular, dinner. You might want to take, in fact, you might want to take all of the metformin, the rapid-acting glucophage, I should say, 2 hours before dinner, so that it will prevent that middle-of-the-night increase. There's a good chance that you don't need insulin before dinner, but we can't be sure of that. That's about all I can think of right now. Type 1 for 7 years. On your program since diagnosis. My A1C is 4.8 to 4.9. And I have blood sugars about 140, less than 10 times above 140, less than 10 times a year. I'm very anxious about complications. Do I need to be? Probably not. One thing I would do is if you are having consistent meals every day, the same thing for from one day to the next, I'd pick a day and check blood sugars every 2 hours. And if you have a steady state of around 83 all the time, you don't have to worry about diabetic complications. Now, most physicians would criticize me severely because remember, the ADA still advocates high blood sugars and and high dietary carbohydrate. If you read the diets they recommend, the products they recommend, so they're trying to pretend that the complications don't happen because of blood sugar. But if you keep your blood sugars normal all the time and once in a while check it all day long, every 2 hours, maybe twice a year. That's it. You don't have to worry. On page 227 of Diabetes Solution, you state that if blood sugar is over 170, it may be unwise to exercise. Can you clarify what kind of exercise you mean here? Well, it's trial and error. Some people, for example, it might be just a long walk, or it might be cardiovascular exercise where you get your heart rate up high, or it might be muscle building exercise. The thing to do is the next time you have a blood sugar over 170, and it might be, by the way, it might be 150 or 160. So the next time you have a blood sugar that high, exercise and see what happens. That way you'll find out what works for you. But if you're running this high with any frequency, you should be reading my book more carefully and doing what it takes so that you don't go up to 170. Type 2 diabetic in hospital with severe hyperglycemia and associated dehydration. Why is the standard remedy for dehydration in the hospital? What is the standard remedy for dehydration in the hospital setting? As I do not understand why they gave 5% dextrose to an already hyperglycemic diabetic. This is tradition. Totally ignores logic, and you might want to take a look at an article that I had published in the Journal of the American Medical Association in 2014. JAMA, Journal of the American Medical Association, Internal Medicine, 2014, page 858. It tells how they almost killed me numerous times when I went in for a few hours for minor surgery. As soon as I came in, before I went in, they advised me not to take insulin, even though I was a type 1 diabetic. When I went in, they immediately hooked me up to IV glucose and kept doing one thing after another that would have killed me if I had not intervened on my own, like turning off the glucose clamp and whatever. So this is tradition. It's the rule for many hospitals. I was in a world-famous teaching hospital that was part of a federally funded, many multi-million-dollar diabetes center, and this is par for the course. Now, if you have objections to this, every hospital in the United States, I assume you are in the United States, has a patient's bill of rights, and you can tell the physician who's caring for you there that he should read the patient's bill of rights, which enables you to talk to the hospital administrator. And you could complain to the hospital administrator about what's being done if the physician in charge of your case refuses to stop the glucose. That's about all I could say. You could read my book, which goes into this in more detail. How would my type 1 diabetes change if I were to go on supplemental thyroid hormone to treat a very mild hypothyroidism? Probably not very much, but it has been shown that the administration of T3, liothyronine, can raise blood sugar. Now, I've been taking liothyronine, T3 and T4. I've been taking them both, I guess, since I started in medical practice. And we talk about it in my book. I don't suffer at all from taking the T3, but there may be people who do find their blood sugars go up. But it's worth it because there are many advantages to having normal thyroid levels in your blood. And I might say that T3 is the active hormone. It's not always possible to keep thyroid levels normal with just T4, which is less active than T3. I must have more like 50 grams of carbohydrate or more per day to stay out of ketosis, especially since I jog. Does this mean there is something wrong with me? Or can we chalk this up to everyone just being a little different? Again, this person is looking at ketones instead of blood sugar. The ketones are part of a natural survival mechanism that enables you to metabolize fat as a backup to the metabolism of glucose. So if you're jogging and you use up a lot of your stored glycogen, you're going to start burning fat and making ketones. There's nothing harmful with that. But I usually have my joggers, and certainly my marathon runners, carry with them liquid glucose to prevent their blood sugars from getting too low, because that could be dangerous. They could end up unconscious, and if there's no one around to help them, they're in big trouble. So I tell the marathon runners to be drinking a little bit of glucose solution every X minutes, and it depends, the X depends on trial and error. And I also tell them to check their blood sugar every Y minutes. The Y might be 10 minutes, might be 20 minutes, unlikely to be more than 20 minutes. And usually I have them take enough glucose to get over their well over their target, because the marathon running will get it down. What the jogging does, I have no idea. It depends on the individual. So it's all trial and error. And having 50 grams of carbs spread out over the whole day may not be the wisest thing to do, but with some intensive exercise, some people find that they will be dropping all day long. So that may require correcting with glucose periodically during the day. Now, let's say you don't want to be taking glucose every few hours. You might find that a slow-acting carbohydrate may work, but it's hard to calibrate them. Or you might find that eating protein on a jogging day, several snacks a day, might be of value. It's all trial and error, and I suggest you read my book, Diabetes Solution. Do you recommend testing for insulin autoantibodies in children when the mother has type 1 diabetes? It certainly makes sense, but I also recommend that you check hemoglobin A1C. And I also strongly recommend that any close relatives of a type 1 diabetic be on a low carbohydrate diet. So my kids, who are now almost older than I am, and that's pretty old, they're all on low carb diets. They're doing this because they don't want to get diabetes. And thus far it's worked. So, and I advise all of my diabetic patients to have their kids follow the same diet that they do. And I likewise tell the parents of diabetic children that the whole family should be on a low-carb diet. I was advised by a needle manufacturer that 4-millimeter length needles should be used on all people regardless of body size. The only time we would use longer needles is if the dose was particularly large to avoid leaking. Does this advice line up with your beliefs? Well, it's not my beliefs, it's my experiments. And what I found when I tested 6-millimeter needles was that if you're trying to fill, and I've said this in my prior videos and teleseminars, if you're trying to fill a syringe from an insulin vial, the thickness of rubber in the stopper is more than 6 millimeters as you get away from the center of the stopper. So you can't even get insulin out of a syringe unless you're out of a vial, unless you're dead center with the needle, if you're using a 4-millimeter needle or even a 6-millimeter needle. So number one, you won't be able to get insulin. Number two, we found that with the insulin pens that were coming with 6-millimeter needles, they were all leaking. And we found that they do much better with 8-millimeter needles. So whether you're using a pen or a syringe, the way to go is the 8-millimeter needles. For intramuscular shots, we use the 12.7-millimeter needles. And for people with a lot of fat over their muscles, even the 12.7 won't give an intramuscular shot. I've been type 1 for a little over 15 years. Last 3 or 4 months is where I've started to follow a very low-carb diet, as described in your book. Lab work came back normal, except for my cholesterol and my spot urine test for the albumin and creatinine. So this person is wanting to know why, and of course, he had no baseline data to compare it to, and most type 1s for that long a period of time will have impaired kidney function, just like I did many years ago. Now, if you want more information about your kidney function, you might get a 24-hour urine and have it checked for creatinine clearance, for microalbumin, and for total albumin. You also might check serum cystatin C, and you might check serum fibrinogen. All of these can relate to impaired kidney function. And the game plan should be absolutely normal blood sugars. And I earlier in this teleseminar spoke of creatinine clearance and how low it can get and still be able to reverse the kidney disease. What happens if your stomach empties fast, called dumping, opposite to fullness and causes of brittle diabetes, the dumping causes brittle diabetes, which I have had now for 25 years. I'm on a pump, but hypos every day for at least 25 years, taking very little insulin. Can I use the injection amylin? I'm only on 22 units a day of insulin, but have very irrational sugars unless I don't eat. Well, first of all, I think this person should read my book, Diabetes Solution. And remember that irrational blood sugars will be caused by using an insulin pump for a variety of reasons, including the scar tissue at the infusion sites, which give you unpredictable insulin absorption. If you really have a dumping syndrome, injected amylin might be of value because it slows stomach emptying, and you would inject it probably 30 to 60 minutes before a meal by trial and error, and it might be effective. And the amount would be experimental. You'd have to do trial and error. You should also do an RR interval study because you might possibly have gastroparesis in addition to the dumping syndrome. It's always worth knowing about that. And that's basically it. Read the book, and you'll get a lot of information. I'm a type 2 on low carbohydrate, moderate fat and protein, 20 carbs per day for the past 2 weeks. Trying not to go over on protein. I don't know what that means. Why are my blood sugars still so high? Granted, they are better, but how are they still in the high 200s fasting? Again, you say you're diabetic. Well, if you're diabetic, it depends how severe. And diet alone may not do the job. You may need insulin. You may need some oral agent. So read my book, Diabetes Solution, and do what it says. As I said, you might need insulin. You can't expect normal blood sugars in a diabetic just from diet alone. If the diabetes is very mild and you're only going up slightly after meals, might be able to treat it with diet. But those people are relatively rare because they've waited too long before going on a low-carb diet, and high blood sugars destroy beta cells. Your book mentions that around 20% of beta cells remain even after elevated blood sugars, and that it is possible for the honeymoon period to remain indefinitely with the proper treatment. In your opinion, how long would this 20% of beta cells remain under the conventional treatment? Well, first of all, this person misinterprets what I said. What the book says is something like this, and I haven't read it for many years, that to start showing high blood sugars with moderate challenge, that is, not on a high-carb diet, you have to have lost 65 to 85% of your beta cells. And you can likely preserve the remaining beta cells if you keep your blood sugars absolutely normal thereafter, by not overtaxing them. And usually it may mean taking insulin. Now, with conventional treatment, this patient is asking, you end up getting a decline. How rapid a decline? With some people, we see very rapid, because conventional treatment varies from endocrinologist to endocrinologist, may even vary from country to country. We know that destruction of the remaining beta cells is pretty inevitable, but how rapid all depends upon the treatment. And you tell me what conventional treatment is. I suggest you read my book. Is it normal for sugar to go up during exercise for type 2 diabetes? Usually not. If the exercise is in the morning hours, let's say 3 to 4 hours before you, after you awaken, there's the possibility of the dawn phenomenon, where much of the insulin you make is being destroyed by the liver. And you do need some insulin to cover exercise, cover the stress hormones you make during exercise. But it also depends on the type of exercise. If you exercise as intensively as I do, it would certainly go up if I did so during the first few hours. So it's all trial and error. You might need my book. It goes into greater detail. Why doesn't a low-carb, high-protein diet cause problems to kidney and heart? Well, one could ask the opposite. Why should it? I had evidence of heart disease 50 years ago that totally reversed, and evidence of severe kidney disease. So you're asking the wrong question. I suggest you read my book. Now, it could be that there are doctors that say that the heart needs carbohydrate. I haven't seen them say this lately. They usually say the brain needs carbohydrate and the heart is is harmed by fat. That's nonsense. And the scientific literature doesn't support it. And if you read, if you keep up to date on the current medical journals, in particular, Journal of the American Medical Association, British Medical Journal, Lancet, they all have articles over the past few months showing that high carbohydrate is the likely culprit when it comes to heart disease. And that's basically it. I'm a type 2 diabetic and wondering if I should manage with insulin with all its hypos or maintain strict diet control and metformin, which has its own side effects. Again, this person should read my book. You don't have to get hypos from insulin if you use it properly. If you use it according to the ADA guidelines, which means high carbohydrate, very high doses of insulin, you won't get predictability. But if you follow the laws of small numbers that we speak about in my book, you're getting so little insulin that you would have to make big mistakes to get hypos. And I might point out that metformin doesn't have a bad side effect profile. Yes, about maybe 15% of users will get initial diarrhea if they use the rapid-acting metformin and or the generic metformin and start with high doses. But we use the generic metformin, we start with the slow-acting, we give it at the end of a meal, and maybe we'll get diarrhea in 8% of the users, and it usually reverses after a few weeks. But there are some people where it doesn't reverse. There is also the possibility that metformin can inhibit vitamin B12 absorption, and that's why we test for it in people who are getting metformin. I have yet to find one patient where it actually did cause B12 malabsorption, but it's in the literature, so we test occasionally. Do you ever prescribe Metanx, Metanx, for peripheral neuropathy? This is a mixture of L-methylfolate and B vitamins. I never prescribe anything for the symptoms of peripheral neuropathy because I see it respond so rapidly to blood sugar normalization. So I've never had a need for any of the painkillers or other systems for treating peripheral neuropathy. It's too bad that doctors ignore the blood sugar and give all kinds of supplements and painkillers for the neuropathy instead of addressing it directly at the cause. I've just recently been diagnosed with MODY, maturity onset diabetes of youth. A1C is 7.2. That's an average blood sugar of something like 188. I eat low carb, still a bit above the 6-12-12 you recommend. I daily skip meals. The endo prescribed a sulfonylurea, which I have not gotten it filled due to your recommendations against it after reading your book. Would you have a better recommendation? Well, yes, I would. The reason we don't like a sulfonylurea is, one, it's very hard to utilize without causing hypoglycemia, if it works, and two, the track record with regard to heart disease is very adverse. There have been repeated studies, and they repeatedly have shown the same thing, going all the way back to the 1970s, maybe earlier. So I would recommend the possibility for glucophage, which is generic metformin. Which is brand name metformin. Avandia. Certainly, well, you're already on a low-carb diet, but make sure you're on the right low-carb diet. And, of course, insulin. An A1C as high as yours probably requires insulin if you're already on a low-carb diet. Please comment on your experience and or knowledge on the intermittent fasting and following your eating plan. From what I've read, well, I had one person who actually did that, and what he did was he lost weight when he fasted for a couple of weeks, and I think it was a partial fast where he cut way back on his intake. And this guy was a wall climber, fake mountains, and his muscle strength declined considerably. He lost weight, so he lost muscle mass and fat mass. And then when he started eating again, he regained the fat and was still weak. And this is what you see in the scientific literature. They lose fat and muscle from fasting, and then they regain the fat, and they have to work all the harder at rebuilding the muscle. I was up to as much as 24 units of Levemir twice daily. My A1C rose from 5.5%, and still my endo wouldn't write me a prescription for bolus insulin, saying it would be better to be at an A1C of 6.0. I went and bought Humulin R over the counter. It seemed fine for a few weeks, very helpful, but then my tongue started feeling numb for the next 2 weeks. The past weekend, my lips and cheeks were partially numb too. I suspect the R insulin is the cause, so I have stopped using it. Is it possible that R could cause such a reaction? Well, you could have had an allergic reaction to the R, but I doubt it very much. What I think happened is that you had low blood sugars, or at least lower blood sugars than you used to have, and maybe even too low. And one of the early signs of hypoglycemia is what's called perioral numbness. That is also called perioral paresthesias. And this perioral numbness affects the lips and the tongue usually. And you're probably not checking your blood sugars. I would certainly check my blood sugars a number of times per day, certainly before and after meals, etc. I think you ought to read my book and see what your blood sugars are. I'm willing to bet that the numbness occurs when your blood sugars are low. If I'm wrong, send a message to the site for this teleseminar. Can you please offer any advice? I am moderately obese with fatty liver, and I am at high risk for heart disease. I'm 66 years old and female. Another person should read my book, either Diabetes Solution or Diabetes Diet. Certainly a fatty liver is very common in people who had high blood sugars. I'm a type 1 diabetic, and when I was first diagnosed, I had an enlarged liver, and I had that enlarged liver for many years, I guess until I was about 35, when I started controlling my blood sugars. And then it used to be hanging way below my right rib cage, and when I touched it, it hurt. And after I got my blood sugars controlled, maybe by a year later, I couldn't feel it anymore. It had vanished. So takes normal blood sugars. My husband and I have been very low carbing and intermittent fasting since January. We are not diabetic. For the past several months, we have seen tremendous spikes in our fasting glucose. The level usually goes down in the 90s or lower within a few hours of eating, but has been as high as the 130s in the morning. Well, maybe you are diabetic. I doubt that the intermittent fasting is smart. You're destroying muscle mass and increasing your insulin resistance by destroying muscle mass. I think that you should get hemoglobin A1Cs, and you may need long-acting glucophage at bedtime. You might need a tiny dose of Tresiba insulin at bedtime, or some Avandia insulin to prevent the overnight rise. Or it could be that you're going up after dinner and your bedtime is late, and it keeps going up overnight from the dinner. There's also the remote possibility of gastroparesis, where your stomach emptying from dinner is delayed. And this might be especially the case if you check in the middle of the night and then go up from the middle of the night to the morning. There are all kinds of possibilities. You might want to read my book, Diabetes Solution. I've ordered some 100% sucralose with none of the added sugars that the stuff in the store shelves has in it. It claims you can cook with it and it tastes like sugar. Do you know if it elevates blood sugar? If it really is 0% sugar, that would be true. But you have to read the label very carefully for the constituents, because if there is an added sugar and it's less than 1 gram per serving, and usually a serving size is 3 grams, the law allows you to say 0, even though that's a lie, and it's really significantly higher. So look to see if there are any sugars on the list. Well, I think that we've finished for tonight. I'd like to tell you about our next teleseminar. Our next teleseminar will be Wednesday, October 25th. Good luck. Have a good month. We'll see you then.